Welcome to the Adult Congenital Heart Disease Basic Teaching course. This module is on aortic coarctation and presented to you by myself, Dr. Samantha Fitzsimmons, Consultant Cardiologist from the University Hospital Southampton in the United Kingdom, and Professor Gruschen Veldtman from the Heart Institute, Cincinnati Children's Hospital. Aortic coarctation is defined as a congenital localized stenosis or hyperplastic segment of the aorta. The typical location of the stenosis is at the ductus arteriosus insertion point, as shown in the diagram below. Aortic coarctation is a generalised arteriopathy, seen in 5 to 8% of all congenital lesions. The prevalence has been reported at 3 per 10,000 live births. Aortic coarctation is associated with other lesions which are important to identify. Cardiac associations include bicuspid aortic valve, seen in up to 85% of those with aortic coarctation, ventricular septal defects, and mitral valve abnormalities. Extracardiac associations include intracranial aneurysms. Patients with aortic coarctation still present to cardiologists in adult life. Symptoms may include persistent or drug-resistant hypertension, extreme exercise-induced hypertension, headache or epistaxis in association with hypertension, or lower limb ischemia and intermittent claudication. Other presentations may include syncope, headache, once again associated with intracranial hemorrhage. Routine investigations for aortic coarctation include electrocardiogram, typically showing left ventricular hypertrophy, chest X-ray showing a double contour at the aortic arch, often described as a reverse 3 sign, with rib notching secondary to intercostal collateral arteries. These are demonstrated on the following slide. Transthoracic echocardiogram can be used to identify any associated lesions such as bicuspid aortic valve, mitral valve abnormalities, and ventricular septal defects. It can also be used to identify left ventricular hypertrophy. Using transthoracic echocardiogram and Doppler probes can be placed in the descending aorta to show high velocity flow and diastolic continuation in the presence of aortic coarctation. This chest X-ray demonstrates the double contour at the aortic arch with the purple arrow and rib notching with the blue arrow. Further specialist diagnostics include computerized tomography or magnetic resonance imaging. More invasive cardiac catheterization can assess both the anatomy of the area of coarctation but also the diagnostics if a significant lesion is present, defined as a pressure gradient across the area of coarctation greater than 20 mm of mercury. Similarly, you can also investigate for associated coronary artery disease. Management of aortic coarctation has advanced remarkably over the years, with surgical techniques improving and the introduction of percutaneous angioplasty. A number of differing surgical techniques have been used over the years, as shown on this slide. It is important for the clinician to be aware of the previous surgical technique used in each patient, as each surgical technique carries its own long-term complications. Figure A shows the end-to-end anastomosis technique, which is quite simply removing the area of stenosis and anastomosing the proximal and distal segments of aorta. Figure B shows patch angioplasty, simply enlarging the area of stenosis. However, older patients with Dacron or dural matter patches have a higher incidence of aneurysm formation at the patch site. Figure C shows an interposition graph. By removing the area of stenosis and replacing this with a graft between the proximal and distal aorta. Other grafts used were a jump graft, which bypasses the area of narrowing in the coarctation site. Where the area of coarctation is very complex, extra anatomical bypass grafts have been used, taking grafts from the ascending to the descending aorta. These are particularly useful in longer segments of aortic coarctation or in more fragile aortic tissue. Percutaneous stenting of the native aortic coarctation was first introduced in the 1990s. Balloon angioplasty alone preceded stenting in 1982, but the elastic recoil of the aortic wall led to a high incidence of restenosis. Covered stents are preferred for native critical aortic coarctation sites. Older, less compliant aortic coarctations, and commonly being used to seal the entry to pseudoaneurysms post-surgery, often seen as a late complication. Bare metal stents are often used where there's a risk of branched vessel occlusion, but unfortunately offer no protection against the complication of aortic dissection. These angiogram stills demonstrate the pre-stenting stenotic aortic coarctation area on the left of your screen versus the stented area of aortic coarctation, relieving the area of stenosis on the right-hand side of your screen. An overview of the long-term outcomes in aortic coarctation is shown here. Complementary to this module, you may wish to view Daniel Tobler's presentation entitled Repaired Coarctation of the Aorta to explore each of these complications in more detail. Despite repair or relieving of the stenosis in aortic coarctation, 25 to 50% of patients remain hypertensive at rest or on exertion. This is thought secondary to the generalised aortopathy found in aortic coarctation. Post-stenotic aneurysm formation or anastomotic site pseudoaneurysms should be considered when following those patients with aortic coarctation. If left untreated, post-stenotic or anastomotic site pseudoaneurysms are at risk of rupture. Restenosis has also been seen as a late complication, particularly after percutaneous stenting. There has been a high incidence of premature coronary artery disease reported in those with aortic coarctation. However, recent literature has shown this may be attributed to conventional cardiovascular risks associated with long-term uncontrolled hypertension. And of course, the natural progression of the associated lesions such as the bicuspid aortic valve with aortic stenosis or aortic valve incompetence. Studies have reported a 10% occurrence of intracranial aneurysms. This CT reconstruction demonstrates the native aorta following the purple arrow and the aortic coarctation pointed by the blue arrow, with a jump Dacron graft highlighted with the light blue arrow and the distal anastomosis site aneurysm highlighted with the red arrow. This patient presented with hemoptysis secondary to the pseudoaneurysm, requiring percutaneous stenting to seal off the mouth of the aneurysm to prevent further hemorrhage. The follow-up post-aortic coarctation repair is extremely important. The American Heart Association and European Society of Cardiology recommend 1 to 2 year follow-up in a congenital specialist centre, with cross-sectional imaging at least 5 yearly, depending on the findings. Aggressive blood pressure control is imperative for the long-term cardiovascular risk in these patients. And once aware of the associated complications, you can ensure careful and thorough follow-up of these patients. This brings us to the end of our web-based aortic coarctation learning module. Thank you for taking an interest in this module, and we wish you well for the future.